Hey everybody, this is Michael Barrier. I am a critical care and flight paramedic with Vidant East Care at Vidant Medical Center in Greenville, North Carolina. And this is PEA, Finding Gold in the Garbage. This is a lecture I did, or a talk I did at the Critical Care Transport Medicine Conference in San Antonio this past April 2018. Down there at the bottom, you'll see the flashing bar, which encourages you to grab the show notes either by snapping that QR code with your phone, or you can click the link below down in the description, which will get you to where you can download a PDF copy of the show notes, the references, and the rules for cardiac arrest. I have no conflicts of interest to disclose. So what the gold in the garbage is the differential diagnosis and treatment of pulseless electrical activity, or PEA. And the trash I'm going to explain in a second. We're going to talk about cardiac arrest statistics in the hospital, out of hospital, shockable rhythms, non-shockable rhythms, and survival, and how all those things relate to the greater topic of PEA. And then we're going to talk more about the causes for PEA arrest, and then our solutions, how we're going to fix that and how we get better. Obviously, that's a big pile of trash, and the inspiration for this lecture came from I was at a gas station one day and saw a much smaller pile of trash there by the pump. And I imagined, to me or anybody else that was at the gas station, that was one thing. It was a pile of trash. When if somebody were to care about the pieces of it, then it was all the sum of its components. It was gum wrappers or soda cans or cups or whatever. And I thought that was a pretty good metaphor for the way that we treat cardiac arrest. Because we often treat cardiac arrest just like the trash we would throw in that one big trash can there on the left. And we focus on a couple of things, which are important and do really well. But when it comes to the differential diagnosis and the causes of cardiac arrest, we could probably treat that in a much more modern way, the same way that we treat our trash, like you see on the right there. We separate our trash into all of its different types. And we should really probably do a better job at separating our cardiac arrest into all of its better types, especially when we think about PEA. So when we think about cardiac arrest, we obviously think about the shockable rhythms, the VFibs. We think about the absence of rhythm in PEA, and we have very specific ways to treat those two things. And when it comes to the organized nature of PEA, we always try to treat that the same way too. And the more I thought about it, just like the trash on the ground, I'm not sure that treating all PEA the same makes much sense. So if we begin with out-of-hospital cardiac arrest statistics, these numbers stay pretty static from year to year. This is 2015. There were about 326,000 out-of-hospital cardiac arrests. A little over half of those were treated by EMS. About half of those were unwitnessed. But only about a quarter, actually less than a quarter, 23% of those patients were found in a shockable rhythm. And that is important in the greater context of our discussion about PEA when we think about survival. Because overall, for those out-of-hospital cardiac arrest, 10.6% of those survived a hospital discharge, slightly less with good neurofunction. But if they were witnessed and were found in a shockable rhythm, that survival went way up to 33%. We consider in-hospital cardiac arrest, we have a similar proportion of numbers. Less cardiac arrest, 209,000 a year. Survival to discharge for those went up substantially, 25.5%. Almost half of those were if they were found in a shockable rhythm. If non-shockable, about 10.5% went home. And a couple of things about in-hospital cardiac arrest. First of all, one source found that half of the cardiac arrest inside the hospital were probably avoidable. And when looked at both with that in mind and with the survival numbers in mind, that's not terribly surprising, because typically if somebody goes into cardiac arrest inside the hospital, we know why they did. And it's most likely related to the reason they were in the hospital in the first place. So if somebody has surgery, then the likelihood that a surgical complication caused their cardiac arrest is pretty high. By the same token, if somebody's in the cardiac ICU or the cardiac surgery ICU, the chance they had a heart condition which led to their cardiac arrest is pretty high. Those things are typically predictable, often avoidable, and easy to trace back, even if they get missed or overlooked. But even though the cardiac arrest numbers, both inside and outside the hospital, stay pretty static from year to year, one thing that has changed over the past decade or so is that the number of VFib arrests as a presenting rhythm has gone down, while the number of asystolic or PEA, the non-shockable arrests, have gone up. And this prompts a really big question as to why that's true. And some of the conventional wisdom from a couple of sources hypothesize that, believe it or not, we are getting better as a society at preventing cardiac death. So in other words, people are eating better, they're exercising, they're taking their medicine, those kind of things. So fewer people are dying of primary cardiac causes, while more people are dying of non-cardiac causes because, as I said before, the cardiac arrest numbers have stayed pretty static. It's only changing what our presenting rhythm is. And so that makes our discussion of what to do with non-shockable rhythms, especially PEA, all that more important. So before we talk about what to do about it, we have to decide what it is. And the great thing about pulseless electrical activity is the definition is pretty much in the name. And that's defined as any cardiac activity which is expected to produce a pulse, which doesn't. That also helps us to work our way into what we're going to find about our patients who may not have a pulse but do have cardiac activity. And we're going to figure out that we're going to do something different with those folks, or at least we should be. So in going down one step from cardiac arrest numbers just to numbers about PEA, they see that out of the hospital, PEA accounts for somewhere between 20 and 34% of the cardiac arrest, whereas almost half of in-hospital cardiac arrest. And again, when you think about the reasons people die in the hospital, that's not terribly surprising. A big disparity, and one of the things we're going to spend a good bit of time talking about, is that 40% of folks in PEA will experience a return of spontaneous circulation at some point during their resuscitation. We're going to get about 40% of those people back, at least for a little bit. However, we're only going to send somewhere between 6.5% and 12% of those people home. So if 40% of those people get their pulse back, but we only discharge about 10% of them home, what happens in the middle? And another way to think about this question is, why are we so bad at treating PEA arrest? Now, when you consider that, don't immediately think that you're terrible at what you do, because I don't think that's true at all. We have to consider, first of all, these people are really, really sick, or they wouldn't have died in the first place. And so one particular source, I came back to this one article several times, it said the reason for the just dismal prognosis for folks in PEA was a lot of those people went into PEA because of significant, massive, unrecoverable damage to their left ventricle. We just weren't going to get them back no matter what we did. So this doesn't get us off the hook for all the causes of PEA, but it goes a fair distance to explaining why these people tend to die and stay dead. It's because they're just very, very sick. Another thing I blame is the data. The way that some of this data is collected, and when I started pulling the articles on PEA, and there's a bunch of them, one of the things I found over and over again was that when people were studying, whether it was retrospectively or through a meta-analysis or whatever, when they were studying people who died and had a presenting rhythm of PEA, they often excluded non-cardiac causes of the arrest, things like trauma, drowning, exsanguination, or electrocution. And what is overlooked by doing that is those are often the things we can do something about. So when you take the cardiac arrest data in that context, it paints a pretty bleak picture of our ability to do anything about it, because it takes away, at least academically, many of the things that we could fix if we were given the opportunity. Another big problem is protocol-driven cookie-cutter medicine. One of the things that I found over and over again in the discussions about PEA was that there was a lot of evidence supporting deviation from protocol. Now, that's not an unscripted deviation from protocol that you should just do willy-nilly, but it was the idea that sometimes you got to leave the page because whatever killed the person isn't written on the page. And so when it's in terms of cookie-cutter medicine, this is what I think of your cookie-cutter. Now, PEA is one of those things which over time has changed a lot, at least in the way we think about it and talk about it. So I'm sure there are those of you listening old enough to remember when we called it EMD. That's what it was when I first took ACLS, was electromechanical dissociation. And I like that name because it really told the story. It was a complete separation between the electrical system and the mechanical system of the heart. Shortly thereafter, we adopted the term PEA, which we still keep today. Also, pretty good at telling the story. Within the past few years, we've adopted something called pseudo-PEA, which essentially just means that while there's no pulse, it's not necessarily cardiac arrest because the heart may still be moving. And the addition of point-of-care ultrasound, or POCUS, has also given us two newer terms, which are PREM and PRES, and bear with me, these are a mouthful. Pulseless rhythm with echocardiographic motion, and pulseless rhythm with echocardiographic standstill. And we're going to talk more in just a minute about how important the idea of point-of-care ultrasound really is. But lest I be left out, I'm going to offer you one more acronym to think about this, and that's PMA, pulseless mechanical activity. If you take nothing else away from this experience, I want you to think that so many patients, and I'm going to give you the specific numbers in just a minute, so many patients who are in what we call PEA actually have pulseless mechanical activity. Their heart is moving. And because their heart is moving, our focus should be entirely different in the way that we support that and treat that. So we're going to come back to that in just a minute. Now, this is always one of my favorite cartoons. It talks about the older CPR instructions we have. But this first block on here is kind of important because one of the things I always tell people, and I'm going to give you several rules of cardiac arrest as we go forward, and one of the biggest rules I'm going to give you is that nobody dies for no reason. And it's got to be one of our jobs and one of our missions, and really one of our driving desires in treating cardiac arrest, to figure out what killed the person. Because if we can't do that, we don't stand much of a chance of saving them. We're going to come back to that a couple of more times. So when we think about whose fault it is, now of course it's seldom a person's fault, it's usually a thing's fault. But when we think about whose fault it is, we are of course left with our ACLS algorithm here. This is the most recent one, 2015. And our guidance for deciding what perhaps caused the cardiac arrest are of course found in our ever-present H's and T's. Now what I've always found interesting about this document is that the H's and T's are all the way down here at the bottom like they're ashamed of them. And what we now know, and what we've really known the whole time, is that in order to conduct a good, thorough resuscitation, we can't just think about our H's and T's or our reversible causes at the end. Our reversible causes belong here and here and here and here and virtually throughout the entire resuscitation, because whenever you begin anything like this, you always have to begin with the end in mind, and the end has got to be fixing the correctable cause. But where they are on the page aside, how valuable are the H's and T's anyway? We parrot these things in every ACLS class we have, and we talk about them a lot. But as far as reversible causes, how well do these things actually predict the cause of arrest? A Swiss study looked at that very thing, and it asked the question, says, is it time to abandon or amend this H and T mnemonic? And what they found in their sources of cardiac arrest is that anything that started with an H accounted for 31.3% of the causes of arrest. Anything that started with a T accounted for 23.6% of the arrest. Now, I'm no math whiz, but that's only a little over half of the patients who died. The remainder were made up in the other category, what I call the O's. And this included things like non-ischemic cardiac disorders, intracranial hemorrhage, accounting for almost 7% of the PEA deaths, and intoxication, which I think is probably going to gain wider prominence as we talk more and more about the opioid epidemic here in the States. So there's a lot of other things at work here that may kill somebody, which result in PEA, which makes our history taking that much more important, and also makes our deviation from these H's and T's all that much more likely. Another algorithm I found attempted to leave the H's and T's and look at the 3 most common causes, which they found to be hypovolemia, obstruction to circulation, and pump failure, and then they further expanded on obstruction of circulation to include the most common causes of that, which were pneumothorax, cardiac tamponade, and pulmonary emboli. But even this leaves out a lot of those other things. This was just intended to simplify that down even further to the most common causes. Not to be left out, I came up with an acronym of my own, in which we go to the planet Hoth. In this case, Hoth stands for hypovolemia, oxygen debt, tension, trauma, and hyperkalemia. Through doing the literature review, I found that these were probably the most common causes that we saw that led to PEA, not only in our country, but worldwide. And we're going to come back to the treatment for those later. So we begin with the assessment of PEA. The very first thing that we have to know about PEA, since it stands for pulseless electrical activity, is that we don't have a pulse. And believe it or not, we in healthcare still don't do this very well. Matter of fact, one discussion found that our ability to check a central pulse was still pretty bad. And you know, you get in the heat of the moment and you got your finger on somebody's neck, and do you feel their pulse? Do you feel yours? You just don't know. And so in terms of assessment, the foundational naming quality of PEA turns out to be that somebody is pulseless is not terribly reliable. So as we go further from that, one of the things that I found was most lacking, and the thing that I think we really have to change our paradigm on, maybe most of all, is the idea that the rhythm itself doesn't matter. So we lump all PEA into the same category when there have been a number of sources which suggest that what rhythm that patient is in PEA is incredibly important. And ask yourself that question when you think about the assessment that you do on living patients. You're looking at somebody's cardiac rhythm at the bedside. Ask yourself, does that rhythm matter? Well, of course it does. What rhythm they're in, whether they're tachycardic or bradycardic or wide complex or narrow complex or whatever those things are all incredibly important. Why would they be less important if somebody didn't have a pulse? It makes zero sense. And so Littman and colleagues developed this really, really good tool for assessing PEA based on the rhythm. And what they found through retrospective analysis was that folks who were in PEA but had a narrow rhythm tended to have mechanical problems. So in other words, they didn't have enough blood to pump, or they couldn't pump the blood for an obstructive reason, so like a tamponade or pneumothorax, or they were hypovolemic. Whereas they found patients with wide complex PEA often had a toxicology or drug problem. So, and they usually needed electrolytes, or they had an electrolyte imbalance. Or another thing they found to that was sodium channel blocker toxicity, in case you're wondering what those are, need a little review. Things like procainamide, lidocaine, flecainide, some of those older generation drugs, they're known to widen the QRS complex and slow down depolarization. And so those things accounted for those wide complex PEAs. And we're going to come back to this later in terms of what we're going to do to treat those things. Now, some of those things seem pretty intuitive. We're going to touch on them a little harder toward the end of the show. Probably the biggest game changer for cardiac arrest care, especially in terms of PEA, has been the addition of point-of-care ultrasound, or POCUS. And obviously I can't see all of you, but if I could, and I ask you to raise your hand if you currently carry ultrasound on your ambulance or your aircraft, not a lot of hands would go up. But I also theorize that if I were to ask this question again next year and the year after and the year after that, more and more hands would go up till eventually it's just what we do, because it's what we do in the emergency department and the intensive care unit for a while now. And that's because point-of-care ultrasound has added a level of diagnostics that we're not accustomed to in acute care medicine, mostly because it takes some of the guesswork out, where we're not just deciding if we can feel a pulse or trying to discern this rhythm or that rhythm. We're actually seeing if the heart is moving. And what we're learning now more and more is that cardiac motion is the key to the differential diagnosis and treatment in pulseless electrical activity cardiac arrest. For example, this particular study looked at point-of-care ultrasound out of the hospital and in the emergency department. They found 3 really important things. First of all, they found that cardiac activity on the initial ultrasound was the variable most associated with survival. So in other words, and that makes perfect sense when you think about that, if somebody's heart's moving, the chance they're going to survive goes up. And you can think about that in terms of a live person. If you're taking care of a patient who's live and well and you put an ultrasound probe on them, chances are they're still going to have a pulse and be alive when you get done with your ultrasound. And so when you think about somebody who's in cardiac arrest, if their heart is moving, you just can't feel a pulse, you're halfway to survival. And all you have to do is find a way to support their cardiac motion. Second thing was that cardiac motion on the ultrasound was the greatest support, or provided the greatest support for deviation from ACLS medication protocol. Now that doesn't mean you get to throw away the whole ACLS book, but what it does mean is that if you have somebody with good vigorous heart motion, then just going blindly forth with epinephrine every 3 or 5 minutes may not be the solution for that. And the idea they have good vigorous motion or any motion at all may support doing something different. And finally, and probably most importantly, was the fact they found that 54% of patients in PEA actually had cardiac motion on the ultrasound. This is huge because up until now, we've worked with, again, the protocols that we had and the assumption that these patients' heart weren't moving at all. When what we know now is that's just not true for well over half of them. And so we know if they have cardiac motion on the ultrasound, then we should maybe be thinking about something different to support that motion. For example, here's a patient who has no pulse, yet their heart is moving, albeit slowly. So maybe we should be doing something different to support that motion rather than just doing compressions or epinephrine or the same garden variety stuff. Probably the most important thing, as we'll touch on later, is finding out why their heart is moving the way it is. Here's another example patient whose heart is moving quite vigorously, and if you can see, when it moves back into view, right up here at the top, there's a bullet in his pericardium, and that's why he has no pulse. So if we can fix that problem or support his circulation around that, the chance he's going to get better goes way, way up. Same is true with this patient. Very hyperdynamic heart that has no pulse. And that is, for reasons unknown, most likely, he's hypovolemic and needs blood or fluid. There's a lot of different ways that we can tell from ultrasound that the patient's heart may be doing the best it can based on the circumstances, and we have to change the circumstances. And for those of you that didn't raise your hand that you have point of care ultrasound, I'm willing to bet that you do carry quantitative waveform capnography or end-tidal CO2. And the good news for you is that there seems to be a really good association between stable end-tidal CO2 and cardiac motion on the ultrasound. This was a really, really small study, but I think a really important one and a big step forward. And where they compared, so during cardiac arrest, they would do CPR. When it came time for a pulse check, while one person was checking a pulse and they were doing these other things they needed to do, another person put the ultrasound probe on the patient's chest, and they were looking obviously for cardiac motion. And their findings were really impressive. So whenever they found patients during that pulse check, now not during compressions, but when they had paused doing no compressions, doing the pulse check, they found that patients who had stable end-tidal CO2s, and their definition of a stable end-tidal CO2 ended up being about 29. They found that 94% of those patients had cardiac activity on ultrasound. And that's a really, really big deal. Because again, as we said before, we've always labored under the assumption these patients didn't have any cardiac motion. And now we know that many of them do, and if they do have cardiac motion, they're probably going to generate a stable end-tidal. What that says for you, if you don't have ultrasound yet, is if you're doing everything you should be doing during the resuscitation and you're generating good end-tidals without compressions, that patient's heart is probably moving, and maybe you should do something different. In the case of their study protocol, what they did if they found cardiac motion was they didn't begin compressions again. They gave a different vasopressor, they gave a fluid bolus, and a lot of those patients survived. Now again, it was a pretty small study, but well worth thinking about, and the link to the full text is in your show notes. So we've established with point of care ultrasound one way we can do better, but how can we go further to do better in resuscitating these patients? Well, there are several ways. And these are things that we can put into practice almost immediately, even if you don't get ultrasound or some of these other fancy tools. Going further in the rules of cardiac arrest, one of the things I've always said, and I truly believe this, is that if we treat dead folks like live folks, they're going to stay dead. And what I mean by that, when I think back to when I got my very first CPR card, which was a good long time ago, several things were true back in those days. First of all, you could fail a CPR class, which now seems just absolutely insane to anybody who's taken one recently. But you could literally walk out of an AHA CPR class without a card because you didn't do it right. And one of the ways you could not do it right was by doing compressions too fast. So in those days, our compressions were 60 a minute. And we had that mannequin that spit the little tape out of its side, and they were able to count how many compressions you did. And if you did more than the 60 a minute, you probably weren't going to pass. And that's because we believed that 60 compressions a minute was about what our pulse rate should be. That's how fast we should be doing compressions. Of course, now we know that's not true. And many other things have changed about the way that we treat patients in cardiac arrest that completely deviate from the way that we live normally every day. And that's important, and that matters. Another important thing in cardiac arrest is if you're part of the code team, somewhere on that team or that resuscitation team, it should be somebody's job to figure out what killed that person. Now, again, this seems pretty intuitive. This is from a friend of mine, Chris Watford. He drew this as part of his pit crew CPR training at his organization. And we have people who have all these different jobs, airway and doing CPR and things like that. And of course, down here in the bottom in the corner, we have what we call the code commander. And out of the code commander comes what I really wish we would come up with a new certification here in my state, North Carolina, of pre-hospital intensivist. And somebody who literally spent the majority of their time, one of these things, thinking about what caused that patient to go into cardiac arrest in the first place. Because it is that knowledge which is truly going to make the difference whether or not we're going to save them. Now, that may be a cause that we find that we can reverse on the scene, and many times it's going to be a cause that we can't. But without finding that cause, our chances of survival go way, way down. There's one article that was in EMS1.com, the link is in your show notes too, about the resuscitation rooms in one of these big hospitals. Every single one had a rocking chair in there, and it wasn't for the reason you might think. It wasn't for somebody one of the family to sit or something like that. It was actually for the person leading the code team to sit, keep their hands off the patient, not be doing interventions or things like that. And so they could be sitting there and receiving input, receiving feedback, and then contemplating about what possibly killed that patient. And so they could guide the resuscitation without being physically involved in that. And I think that's incredibly important, especially in the context of PEA. Our next rule of cardiac arrest is the only things that have ever been proven to save anybody in cardiac arrest are good CPR, early defibrillation, and correcting the cause. Everything else, the evidence is pretty soft on. And one of these we can go ahead and cross off right now, because if we are defibrillating PEA, we've got bigger problems. So from that, we can move on to good CPR. And I don't think anybody, especially in this day and age, is going to dispute the value of good quality compressions. That's probably been the biggest change in cardiac arrest care in the last 15 years. But how important is that for somebody who has cardiac motion already? Going back to the simplified tool for teaching PEA, they talk about how if somebody has cardiac motion, then overzealous mechanical ventilation, cardiac compressions, epinephrine, which we're going to get to in just a minute, all those can be harmful if they are done out of the clinical context. This also points out something else we need to talk about, which is hands-only CPR. Now, I have no doubt in my mind that hands-only CPR has saved many, many lives since its inception a few years ago. We took away the idea that people who were lay people doing CPR had to do mouth-to-mouth ventilations. I think once we took that away, it took away a lot of people's hesitation about exposure and things like that, and more people were willing to do bystander CPR. Well, the interesting thing about hands-only CPR is in the context of the people to whom we do it. So if somebody goes into cardiac arrest from a drowning, or from out of a fire from smoke inhalation, or from confined space, or in space itself, they have gone into cardiac arrest for hypoxia. And one of the biggest things that we should understand about hands-only CPR is that it is almost useless for hypoxic arrest. And in one of these other studies we looked at, hypoxia accounted for about 23% of their PEA arrests. So a quarter of the patients they encountered who in PEA would not have benefited from CPR that used hands only. And the reason for this is pretty clear. This came from Dr. Justin with Lifeguards Without Borders. He explained this probably the best I've ever heard it, is that think of oxygen as your fuel. And if somebody goes into cardiac arrest for a cardiac reason, so they have a heart attack and they drop dead, they're in public, chances are they still have some gas left in the tank. So their heart just stopped pumping their already reasonably oxygenated blood. And so if we come behind them and begin doing vigorous cardiac compressions and compressions only, we're going to circulate a lot of fairly oxygenated blood, hopefully enough until we can get them defibrillated or fix whatever the problem was. However, if somebody drowns or is asphyxiated for whatever reason, the reason they die is because they run out of gas. They literally run out of oxygen, so they're going to brady down until they eventually become asystolic. Well, if we encounter them in the middle of that process, then we're going to encounter a car essentially with an empty gas tank. And so all the compressions in the world are not going to fix them without adding more gas to the tank. So these kind of folks are going to need ventilations in addition to compressions because they are truly out of gas. Even the Heart Association, they came out with this nifty hands-only CPR fact sheet last year. It goes through all these ways that hands-only CPR are fantastic. Then down at the bottom in big red letters, they tell you if the patient goes into cardiac arrest because of drowning or a drug overdose or other reasons that are breathing related or hypoxia related, you still have to do the ventilations. Now, do not get up from this video and tell people that Michael told you not to do CPR on patients without a pulse, because that is not what I said. What I did say is that somebody who has cardiac motion or somebody who died from a clearly hypoxic or a ventilation related incident, good CPR is probably not going to be enough to make the difference to save them, and you're going to have to manage their airway also. And while we're on things that may work or may not work, let's go ahead and talk about epinephrine, the old Epi-train. Epinephrine has been clearly linked to incidents of increased return of spontaneous circulation during cardiac arrest. It, however, has not been linked to increased survival to hospital discharge. And the reasons for that are becoming clearer and clearer. There's a lot more evidence and a lot more studies underway now which seek to answer those questions about epinephrine. But my working hypothesis for this comes with the concentrations of adrenaline that we normally operate under. So at rest, like presumably you are sitting there listening to me talk, our adrenaline concentrations is about 10 nanograms per liter. So really, really small amounts of adrenaline circulating through our body at rest. Under stress, which is probably closer to what I'm feeling as I record this video, it's somewhere in the neighborhood of 50 nanograms per liter. During vigorous exercise, that concentration jumps way up to like 500 nanograms per liter. When we inject somebody with a milligram of epinephrine based on normal blood volumes, we are approaching concentrations of 200,000 nanograms per liter. An epinephrine injection is an atomic bomb in somebody's body of adrenaline, and we know, of course, how powerful epinephrine or adrenaline is. And so it is no wonder that we're going to generate a pulse with that. I mean, we can make just about anything beat with that much adrenaline. The problem is we have a real hard time communicating those effects or prolonging those effects into the long term. And so this may help us answer the question that we asked earlier in the show, which is if 40% of these people achieve ROSC, yet only 10% go home, what's in the middle there? What's in the middle there is probably the Epi-train, is why a lot of these patients are achieving ROSC at some point, but we can't manage to keep them alive long enough to send them home, which brings us to our next rule of cardiac arrest, which is the Epi-train will get you to the hospital, but probably won't take you home. We go back to the data for a minute about some of the problems here, and this is a problem that just doesn't necessarily exist in the literature, but it exists throughout a lot of our references that we go by in cardiac arrest, and that's we tend to treat rhythms not as VFib and asystole and PEA, but we treat them more bluntly as shockable or not. And when we lump asystole and PEA together as just not shockable rhythms, we do our patients a pretty big disservice. So imagine for a second that you're talking to somebody, and let's say it's me, and we can assume that right now I'm in this particular cardiac rhythm. I'm in normal sinus rhythm. And let's say for whatever reason I go into cardiac arrest. Now, the evidence will suggest that when I go into cardiac arrest, I'm going to be in this rhythm, VFib. Now, let's assume that I've made you mad enough that you're not going to help me, and I'm just going to lay there and continue about the business of dying. Well, eventually I will go from this rhythm, and I will eventually end up in this one. That is a natural progression. I will go from an organized rhythm to a disorganized rhythm to no rhythm at all. And if you didn't help me, I'm going to remember you. So if we believe that that is a natural progression of things, then why would we believe that if somebody's in an organized rhythm, and make no mistake, PEA is organized. That's what makes it the rhythm that it is. If somebody's in an organized pulseless rhythm, what sense does it make to believe that we would take that rhythm and we would make it better by making it disorganized? Yet that is often the perception that we have, is that we should take non-shockable rhythms, PEA and asystole, and in order to improve them, we should make them shockable. And that makes no sense whatsoever. And this is supported by evidence. Probably one of the best studies I read when I was going through this said that conversion to shockable rhythms is associated with better outcomes in out-of-hospital cardiac arrest with patients in asystole, but not PEA. Which brings us to our next rule of cardiac arrest. Making PEA shockable is bad. Taking a rhythm that is organized and purposely wanting to make it disorganized is completely wrong. What we should do in those cases, if somebody has an organized rhythm, is we should seek to support that rhythm. Many times, of course, now we know 54% of the time they're going to have cardiac motion. So they're not really in cardiac arrest at all. They are in hemodynamic arrest. And we have to find ways to support their cardiac motion to return their hemodynamics. And this gets us to the last thing on our list about correcting the cause. And this brings us to our next rule of cardiac arrest, which is our chances of survival are precisely 0 without finding and correcting the cause. Now we know that we encounter patients in cardiac arrest, if we find them in PEA or whatever rhythm we find them in, many times we may think we know what caused that. We may know or have reason to believe it was a sudden cardiac death, or it was secondary to a myocardial infarction, or it was traumatic or whatever. And maybe those things are beyond our capabilities to fix at the bedside or at the patient's side in their home or wherever we find them. But that doesn't mean that we don't know what the cause is and we need to get it fixed. And so this supports the idea of doing those resuscitations a little longer until we can get them where that can be done. We go back for a second to this simplified tool for treating that. And not only does it talk about the differentials between the complex width, whether that's narrow complex or wide complex, it also gets into what those treatments ought to be. And one of the things they recommend for narrow complex PEA is fluid, lots of fluid, for the idea that this is either a hypovolemic problem or it's an obstructive problem. Either way, fluid can help you overcome that. And then it gets into the more fine treatments about how to get rid of the obstruction or whatever the problem is, whether that's pericardiocentesis or needle decompression, changing your ventilator settings, or getting rid of the pulmonary embolus. For patients with wide complex PEAs, rather, this is going to be a little different. They're going to require some more pharmacologic management, like with electrolytes, calcium, and bicarb. So we go back to the Hoth acronym earlier we talked about and how we win the Battle of Hoth. If somebody's hypovolemic, obviously we put back whatever they're leaking. So if they have been, had a long history of vomiting and diarrhea, then we're going to put back fluids. If they're bleeding, we're going to put back their blood and hopefully stop the leak. If they have an oxygen problem, we're going to fix their oxygen problem with their airway. If they have some sort of tension or trauma, then we're going to decompress that if we're able to, and if not, we're at least going to identify it so somebody else can. And then if they're hyperkalemic or some other electrolyte derangement, we're going to fix that specifically. So no more blind treatment of PEA just by the algorithm. We're going to really find our way further and further down, even past the H's and T's, to figure out what's killing them. That brings us to the last part of this, which is traumatic cardiac arrest. And not long ago at our shop, I was tasked with rewriting the traumatic cardiac arrest protocol, and I was stuck somewhere between writing something that looked like this, which incorporated every possible way that somebody could die from trauma, and then there was the protocol that I wanted to write, which looks something much more like this. Just fix the problem, whatever that problem is. Because by doing that, you do a couple of things. You identify what the problem is and you fix it, and you don't spend a lot of time fixing things that aren't the problem. And that leads us to our last rule of cardiac arrest, specifically traumatic cardiac arrest. And that's to say, people in PEA and trauma aren't dead until they have a tube in their trachea, holes in their chest, and empty fluid, preferably blood bags, laying on the floor. Until you have isolated all the possible things that you can fix about what may have killed them, you can't say they're dead yet. Because I think this is where we're losing a lot of the patients we could save in PEA, is by not fixing their problem and just assuming they're going to die anyway. So to wrap it up, most important thing about PEA is finding the killer, figuring out what made that person go into cardiac arrest, and then fixing it. And in fixing it, we're also not going to spend a lot of time in not fixing the things that didn't kill them. So instead of just following our way down one step at a time through the ACLS protocol, really thinking outside the box to fix that. We're going to follow our rules of cardiac arrest. And here those are again. You can review those. They're also in the show notes if you want to go download those. We're going to throw away the cookie cutters, again, getting ourselves out of the box that ACLS has kind of kept us in. And if you are able and you have the idea to start thinking about point of care ultrasound, start educating yourself and start having those conversations with your medical director and your peers and your administrators to think about if that is something that is useful and feasible and possible to add where you are. Thanks so much for watching. You can snap either one of those QR codes. The one on the left will get you the show notes. The one on the right will get you my contact information, which is, of course, there on the screen. Also got links down in the description if you need anything from me. And thank you so much, and I'll be back with you soon.